Welcome to this webinar from the World Federation of Hemophilia on improving care for people with von Willebrand disease. Today's webinar is going to cover the recently published ASH ISTH NHF WFH 2021 guidelines on the diagnosis and management of von Willebrand disease. I want to welcome everyone for joining us today. My name is Nathan Cannell. I'm a hematologist at the Brigham and Women's Hospital and Harvard Medical School in Boston, and I served as the clinical vice chair of the guideline panels for both diagnosis and management of VWD. Today's session, during this webinar, there will be simultaneous interpretation in Spanish, French, Arabic, and Russian. If you're using your computer or tablet, please click on the interpretation button at the bottom of your screen to select the language. If you are joining by mobile phone, there are additional steps that you need to do. The image on the left shows an Android phone. Click on the three dots to select the interpretation channel. The image in the center shows an iPhone. Select the language interpretation option, pick the language, and make sure you click Done on the upper right corner of your screen. If you don't click on Done, then your language selection will not be saved. Our agenda today is to go through a brief introduction to the guideline development process, provide an update on the diagnosis of von Willebrand disease, followed by an update on management. And then we're going to spend some time exploring patient perspectives about living with VWD and the impact of these guidelines. And we'll have plenty of time at the end for a panel discussion with questions and answers as well. The guidelines are freely available around the world to anyone with internet access. If you go to www.bloodadvances.com, you'll be able to access both of the guidelines and the associated work that has been published along with this, including extensive analyses of the medical literature to date. Today's speakers, I am joined by Dr. Michelle Lavin, who is the chair of the WFH von Willebrand Disease and Rare Bleeding Disorders Committee. She is a consultant hematologist at St. James's Hospital in Dublin and serves as a co-chair on the ISTH VWF Scientific Subcommittee and on the European Association of Hemophilia and Allied Disorders Women's Health Committee. Nicolas Giraud has been involved with the French Hemophilia Society since 2010, being part of the executive board since 2015, and became the first president in 2018 concerned with VWD. After completing specialized training to become a patient resource, he conducts therapeutic education workshops with health professionals. Nicolas has also participated in an interdisciplinary health professional group to create national empowerment program sessions for patients with VWD and their families. Nicolas has 3 children and resides in Vienna, Austria, and he also served as a patient representative on our diagnosis panel. Baiba Zimla is a WFH board member and president of the Latvian Hemophilia Society and of the Latvian Alliance of Rare Diseases. She is also a member of the European Hemophilia Consortium VWD Committee, and Baiba is one of 4 people with VWD in her immediate family and has devoted her life to advocacy of people with bleeding disorders in Latvia and internationally. So I thought I would start off today's session with a brief introduction to von Willebrand disease and then talk a little bit about how the guidelines were developed before we discuss the diagnosis. I have no disclosures related to this talk. And all of this starts a little less than 100 years ago with ERIK von Willebrand, a physician who published the first reported family with von Willebrand disease. And at the time, it was referred to as hereditary pseudohemophilia. And this is because even though it seemed very similar to hemophilia in terms of clinical manifestations, it affected men and women equally. And so it seemed to be related, but not exactly like hemophilia. Von Willebrand disease is the most common inherited bleeding disorder and affects men and women equally in terms of inheritance, but disproportionately often affects women because of heavy menstrual bleeding and bleeding after childbirth. Von Willebrand disease results from a decreased amount, an absence of, or decreased function of von Willebrand factor, a key clotting protein in the blood. And bleeding is commonly what we refer to as mucocutaneous, easy bruising, gum bleeding, heavy menstrual bleeding, postpartum hemorrhage after childbirth, and along with bleeding after surgeries. But depending on the severity of VWD, it can involve joint and deep tissue bleeds. The guideline development process is something that was new to many of us who were involved in this effort. And so we were led through this by a fantastic evidence synthesis and knowledge development team. We looked back at previous guidelines for von Willebrand disease, and really what had been published to date was in 2007, after an expert panel was convened by the National Institutes of Health in the United States in consultation with the American Society of Hematology and other stakeholders. This looked at literature published through 2006 and was published in December of 2007. In 2015, the United States National Hemophilia Foundation convened a strategic summit on von Willebrand disease, and a key recommendation was that a well-qualified or authoritative organization or a consortium should develop a new and updated evidence-based clinical practice guideline on VWD. And through a bit of serendipity, several organizations came together to produce these guidelines. And again, you can find them on bloodadvances.com. There are separate documents on diagnosis of von Willebrand disease and management. The objectives of our collaboration between the American Society of Hematology, the ISTH, the NHF, and the WFH, in conjunction with Kansas University Medical Center's evidence development team, was to facilitate clinical decision-making regarding the diagnosis and management to contribute to better health outcomes, quality of life, and health equity. It was important to increase access to appropriate diagnostic testing and therapeutic options, to identify research priorities, and to guide healthcare providers, patients, payers, and other stakeholders as to priority focus areas in VWD. The guideline development process starts with bringing together a panel, and each guideline panel was formed for a balance of expertise, including disciplines beyond hematology. So while there were hematologists, we also had obstetricians and gynecologists, there were pediatricians, we had a nephrologist as part of the team and a dentist as part of our overall team. So there was a lot of expertise, but we also included patients in this process, which was fairly unique to this guideline development in VWD. We also paid close attention to management and minimization of conflicts of interest to make sure it was guided by the evidence. We created 10 to 20 clinical questions for each panel, and this was in what we call the PICO format. Essentially, you take a population of interest, you look at an intervention such as a treatment or diagnostic test, compare it to a different treatment or diagnostic test, and look and see what happens. So for instance, in patients with VWD and a history of severe and frequent bleeds, should routine prophylaxis with concentrate or no routine prophylaxis be used? The evidence synthesis team generates a summary for each PICO question, and we layered in resource use, feasibility, acceptability, equity, as well as patient preferences and values to generate the recommendations that you see in the publication. Now, this is a very busy slide because this is trying to summarize everything that happens over a period of 4 to 5 years is really what it took to do this. So we formulate the questions, look at the evidence, and generate these evidence profiles. And these are available online with the publications, and each publication has several hundred pages of evidence profiles available for anyone in the world to review. We come down to the recommendations and this framework that you'll see, and at the center of all this is the panel guiding this with clinician experts, patient experts, and methodology experts. To inform the work, we used a scoping survey, and we received responses from 71 countries across 6 continents, with over 600 participants and over 9,000 comments. And this was an overwhelming response, suggesting that yes, we do need to focus more on von Willebrand disease. And this information has also been published open access in the journal Hemophilia. After we came up with the draft recommendations, there was a public comment response. And we had more than 100 people from 38 countries provide feedback on the draft recommendations that were then taken back to the panels to incorporate and finalize the recommendations. When you look at the recommendations, you'll see strong and conditional recommendations. With a strong recommendation from a patient perspective, most individuals would want this intervention. And for clinicians, most individuals should receive this intervention. A conditional recommendation for patients means a majority of patients would want the intervention, but many would not. And specifically for clinicians, we note that different choices will be appropriate for different patients depending on preferences and values. For policymakers, this helps them decide, is this something that should be adapted as policy, or does it involve substantial debate among stakeholders? For this guideline, the context that the panels took was a perspective of a high resource setting. We realized that not every place in the world was going to have access to all of these therapies, but we wanted to say, in an ideal world, what might be the goal of optimal care? And this would also inform advocacy efforts and policy work as a goal for individual countries and regions to move toward. In guideline development, there's a term called adolopment, which combines adaptation, adoption, and de novo guideline development. Thinking about adapting the work to your particular region, adopting the guidelines that are most important in an area, and thinking about what areas need purely new guidelines developed because of the specific needs of an institution or region. It's also important to recognize that our patient panelists were full voting members and provided input throughout the development process. The diagnosis panel met separately from the management panel. I do want to provide special appreciation to Dr. Paula James, who served as the clinical co-chair for the effort, and Reem Mustafa, who served as the methods co-chair for this. For the VWD management panel, the clinical co-chair was Dr. Veronica Flood, and as you'll see, Dr. Reem Mustafa also served as the methods co-chair. And so Dr. Mustafa and I were on both panels to provide coordination of the effort. Behind the scenes, there was a methodology team who spent thousands of hours reviewing the medical literature, summarizing the available data, and providing us the information that we used to come up with our recommendations. The diagnosis guideline covers bleeding assessment tools, assays of platelet binding activity for von Willebrand factor. What do you do with the VWF level that normalizes with age? What should the diagnostic thresholds be for type 1 VWD? And specific attention to type 1C VWD. And then extensive recommendations on the assays and diagnostic thresholds for type 2. The management guideline covers prophylaxis, use of desmopressin, challenges and trials, antithrombotic therapy, including anticoagulation and antiplatelet agents, management around major and minor surgery. There's a specific section on gynecology for heavy menstrual bleeding, and also obstetric management around neuraxial anesthesia such as epidurals, as well as management of postpartum hemorrhage. I'm going to move at this point into a discussion about the diagnosis guideline. And I wanted to focus on was one of the most awaited recommendations from this guideline effort, which was the diagnostic threshold. The NHLBI guidelines in 2007 had recommended less than 30%. And so our PICO question was for patients with an abnormal initial screen suspected of type 1 VWD, should the cutoff be at VWF levels less than 30% or less than 50%? And the recommendation that came out of this was that the panel recommended a level less than 30 regardless of bleeding, and for patients with abnormal bleeding, a level less than 50. And this was a strong recommendation on low certainty of the effects. We gave special remarks about what this level refers to, and that the lower limit of the normal range should be used if it is less than 50. And recognizing that testing, with the timing that you test VWF levels can affect what the interpretation may be. There were 9 studies that looked at this issue of correlating levels between laboratory assays as well as diagnosis. And there was a sequence variant frequency. And as you can see, the percentage of individuals who have a genetic mutation in VWF starts to increase when you drop below 50%. And patients who have levels less than 10% almost always have genetic mutations. We also recognize that patients between 30 and 50 have significant bleeding and abnormal bleeding scores. And this was to recognize that there are many patients who have low levels who don't have a bleeding phenotype, but we wanted to ensure access to therapy. When we looked at the likelihood ratios, this was an area of discussion of 40 versus 50, and even considering up to 60. And the panel ended up settling on 50, but made a specific call out for more research around these diagnostic threshold cutoffs. The panel is placing high value on not missing the diagnosis, especially in patients who bleed, and avoiding overdiagnosis in patients who do not bleed. And even though there was low certainty, this was one of the few strong recommendations in the guidelines for 2 reasons. Because we wanted to ensure an explicit diagnosis, especially for access if there's a bleeding phenotype, and to also ensure international uniformity so that each center wasn't setting their own threshold. We specifically asked for detailed data for patients with VWF levels between 30 and 60, including outcomes for bleeding with procedures, and what is the prevalence of a concomitant bleeding disorder, such as a platelet function defect? Is that enhancing the low level and causing the more severe bleeding phenotype? We also think it's important to further study why patients may have bleeding symptoms and what is it like in their family, trying to get better information about the genetic inheritance and the correlation of bleeding. There were some other key diagnostic recommendations related to bleeding assessment tools. And so we do recommend if there's a low probability of VWD, typically that's seen in the primary care setting, we do recommend using a validated bleeding tool. And we provided a conditional recommendation about using newer assays to measure platelet binding activity, such as GP1BM and GP1BR, over the standard ristocetin cofactor assay. And that's because of difficulty in performing this assay and getting accurate and reliable results. Finally, there were guideline algorithms published along in the manuscript, and this goes through use of bleeding assessment tools, thinking about what levels should be considered 50, 30 to 50, and less than 30. And then a very specific evaluation of ratios for type 2 von Willebrand disease, thinking about type 1C von Willebrand disease, reconsidering the diagnosis in patients who have normalized levels, and also genetic testing in the type 2B subtypes, the type 2 subtypes. There are also more detailed algorithms about going through type 2N and type 2B von Willebrand disease. So there's quite a bit of information in detail. So thank you very much. And at this point, I'm going to turn things over to Dr. Lavin to talk about management.
Great. Thank you very much, Nathan. It's fantastic to have the opportunity to speak to everyone today, and I think I'd echo Nathan's enthusiasm for these guidelines. It's fantastic to, at this point, after a long period of discussion and development of these guidelines, who are actually presenting them to the people that matter, the people who have VWD, and hopefully will be seeing the changes of this work. So in terms of my disclosures, they're here. And for management of von Willebrand's disease, I'm going to briefly go through the key aspects of the guideline, divided into general bleeding, looking at surgical management, looking at HMB in pregnancy, so heavy menstrual bleeding is HMB, and looking at aging. So starting with the treatment options for von Willebrand's disease that I'm going to reference throughout this presentation. Many of you will be familiar and have treated with these previously. Tranexamic acid is either given normally in tablet form as an outpatient, but if you're in hospital, it may be given intravenously or as a mouthwash. And that just really helps in terms of clot stabilization and to stop bleeding. Desmopressin is a drug that's also called DDAVP. It's given intravenously into your vein, or it can be given under the skin. And this medication is also available intranasally, so as a nasal puff, but that's in short supply at the moment. This boosts your von Willebrand factor levels, but not everyone with von Willebrand's disease will respond. There's VWF replacement therapies, and they can either be recombinant or derived from blood products, so plasma derived. But it's also important that we don't forget things like iron and hormonal therapies. And they're very important if you start developing iron deficiency from frequent bleeding. And hormonal therapies can be used in women who have problems with heavy menstrual bleeding. So starting with the guidelines regarding kind of more general bleeding symptoms in von Willebrand's disease, the first point in the management guidelines, and probably one of the more important issues that came through from the scoping survey, and particularly from the patients, was looking at where's the role of prophylaxis in von Willebrand's disease. So although prophylaxis is very well established in the treatment of hemophilia, we find that in fact, for patients with von Willebrand's disease, they may not have access, or it may be difficult to obtain prophylaxis. So we looked at the evidence base, and it's now recommended in patients with von Willebrand's disease with a history of severe and frequent bleeds. The guideline panel has suggested using long-term prophylaxis rather than no prophylaxis. Of course, for everybody on prophylaxis, the bleeding symptoms and the need for ongoing prophylaxis should be assessed on a regular basis. But it is hoped that this guidance will provide more support for not only physicians, but importantly patients to access prophylaxis for the treatment of von Willebrand's disease. And when you look at the evidence base comparing this, it is difficult to make a strong recommendation because there's very limited data in comparison to hemophilia studies. So there was one randomized controlled trial comparing prophylaxis with placebo, 5 studies which were set up to have an explicit comparison between pre and post prophylaxis, so before somebody went on prophylaxis, the number of bleeds, and then the number of bleeds after they commenced prophylaxis, and 8 with an implicit comparison between pre and post prophylaxis. And this is all available, as Nathan mentioned earlier, on the link that's seen below on this slide, so you can review the evidence yourself. In terms of other treatments in von Willebrand's disease, DDAVP trials, many of you may be familiar with them, they take an entire day out of somebody's life because you have to come in, have a blood sample taken, have DDAVP administered over 30 to 60 minutes, and then have blood sampling taken sequentially throughout the day. That's usually taken at 1 and 4 hours at a minimum. Some centres may even bring you back for a 24-hour sample. So the guideline addressed who needed a DDAVP trial. And it's now suggested that in patients with type 1 von Willebrand disease, whose baseline levels are less than 30%, that these individuals should still continue to have a trial of desmopressin, and that then it should be used based on the results. So whether you respond or not, that should be the key decision as to whether this can be used in further treatment. And this is because in this group of patients with levels less than 30%, they actually can have very differing responses, and you can't guarantee a response to DDAVP. So it's important to establish that before it's used for surgery. In contrast, however, this is a new change that in adults with type 1 von Willebrand disease and a baseline level of 30 to 50%, these would have been referred to previously as low VWF, that they can be presumed to be responsive to DDAVP or desmopressin. So they no longer require a trial, and they can instead have confirmation of their response at the time of first use, be it for a procedure or for surgery. This doesn't apply to children, as the responses in children can be more variable, so it's still important in children that a DDAVP trial is considered if appropriate. And I've just compiled this table because I think it can be somewhat confusing as to who's suitable or unsuitable for DDAVP. So green for go, so if you're type 1 with a level of 30 to 50%, that you would respond, adults will respond, children still need a trial, and if you're responsive, then it should be used as a first-line therapy. If your levels are less than 30% with type 1, you should have a trial first, and if you respond, then it can be used. In type 2 von Willebrand disease, the responses tend to be either a partial response or a shorter lived response. So it may still be possible to use for minor bleeding. But in type 2b, we don't use it because it can worsen low platelets. Patients with type 3 will typically not respond. So what about surgery? Well, there have been some confusion because depending on which guideline you looked in the past, for either minor surgery or major surgery, different thresholds were used. Some guidelines advised monitoring of both factor 8 and the von Willebrand factor activity. Some recommended factor 8 monitoring alone. And the thresholds different for minor and for major surgery. The duration of follow-up also differed significantly. Following review of the evidence, it's now recommended that both the factor 8 and the von Willebrand factor activities should be followed in patients who are post-operative. And depending on the surgery, we recommend keeping levels greater than 50% for at least 3 days. Obviously, this will be longer in major surgery. For minor procedures, it's also suggesting the addition of tranexamic acid. So there's now more of an emphasis on the use of tranexamic acid to reduce bleeding risk. If your levels are, if you have type 1 von Willebrand disease with a baseline level of 30 to 50%, a mild bleeding phenotype, and you're having a minor mucosal procedure, it's now suggested that you could have tranexamic acid alone over therapies to boost your von Willebrand factor levels. And there's a note in the guidelines that patients, of course, we have to consider individual risk. So for those at higher risk of thrombosis, it may be desirable to avoid the combination of extended increased levels and extended use tranexamic acid. So it really just highlights the importance of patient-centered care. What about the management of heavy menstrual bleeding? Well, I'm just summarizing this in a kind of pictorial form. First of all, I think the key question is the woman planning to conceive? And if you are planning to conceive and you have heavy are not planning to conceive and you have heavy periods, then the choices should be between hormonal therapies such as combined oral contraceptive pill or the intrauterine devices, or therapies such as tranexamic acid, and that's recommended over DDAVP. If you're currently planning to conceive, then your options are more limited because hormonal choices are not suitable. So you should choose we would suggest the choice of tranexamic acid over DDAVP. And here is that guidance again in Word format. I think it's also important just to put a little mention in here that if patients have very severe heavy menstrual bleeding that is not responding to current treatments, that could fit the criteria for prophylaxis, where the definition was severe and frequent bleeding. So don't forget the possible role for prophylaxis if other treatment options have failed. What about pregnancy? Well, the guidance touches on spinal anesthesia, so epidural anesthesia. And they looked at whether a higher target level of von Willebrand factor, target von Willebrand factor level was required. So should you have a level between 50 and 150% or greater than 150% to allow neuroaxial anesthesia? And because of the lack of evidence in this area and the proven record of use of the level greater than 50 for epidural anesthesia, the panel has suggested targeting this threshold of 50 to 150% in order to allow neuroaxial anesthesia. For postpartum bleeding, I think this is one of the main changes in terms of individual patient care that we're going to see, is that the guideline panel has suggested the use of tranexamic acid over not using it in women with type 1 or low von Willebrand factor levels. And note that this may also apply to those with type 2s and type 3 von Willebrand disease. So this would be to use tranexamic acid medication to prevent bleeding after your discharge from hospital during the postpartum period. And this was actually probably the closest we got to having a stronger recommendation. Was a vote on it, and it's down as a conditional recommendation. And that was based really on the low certainty of the evidence, but the low perception of risk in terms of and the chances of increased benefit for women. So in terms of aging, I'm going to briefly steal from the diagnosis panel. So this actually is in the diagnosis guideline, but I think it leads nicely into the next management question. So there was, can you outgrow von Willebrand disease? And this is because we know with aging, both aging and comorbidities can increase your von Willebrand factor level. So if your level goes greater than 50, then do you still have von Willebrand's disease? And the recommendation from the diagnosis panel is that the diagnosis should be reconsidered as opposed to removed. If you have previously confirmed type 1 von Willebrand's disease and now your levels have normalized with age. And this is important because the association between increased levels and bleeding symptoms is not established. So it is not clear that if your levels increase, that your bleeding will definitely abate. So we don't want people to remove the diagnosis from these individuals because they still may need the treatment and care through a haemophilia centre. What about other problems associated often with aging? As we have an older population of people with von Willebrand's disease, they may require the use of antiplatelets or anticoagulation for cardiovascular disease. So if you have heart disease and you need something like aspirin, after probably decades of hearing that you can't have it, well, what is their advice? And in patients with von Willebrand's disease and cardiovascular disease who require treatment with antiplatelets, the panel has suggested giving the necessary treatment over no treatment. And it's of course important that the bleeding risk is reassessed throughout the course of treatment. And there's some good key good clinical practice statements associated with this recommendation. And that's that the multidisciplinary team input is required prior to any decision. And that should be made with the patient where they're educated regarding the risks and benefits, so that there's an informed and shared decision-making process. And this is really at the heart of so many of the recommendations in our guideline. There's also a note that prophylaxis may be required depending on the bleeding phenotype or the baseline von Willebrand factor levels, and that patients with cardiovascular disease are generally unsuitable for DDAVP. So how did these guidelines change practice? Well, we have new diagnostic thresholds, as Nathan has mentioned, for type 1 von Willebrand's disease and also for type 2. There's no DDAVP trials now recommended for those with type 1 von Willebrand's disease and levels in the 30 to 50 IU per deciliter range with a bleeding phenotype or low von Willebrand factor patients. I think it provides clarity regarding the post-operative monitoring. Importantly, it provides support for prophylaxis for both patients and physicians. And it really underscores the importance of individualized approach to patient care, particularly when you look at, say, for example, the cardiovascular disease and antiplatelet use. The use of tranexamic acid in the postpartum period is a very new change for us, and that will be carefully followed to see how that impacts on patient outcomes. The limitations of the guidelines are that, well, we're trying to cover 7 subtypes of von Willebrand's disease and 10 management and 10 diagnostic questions. But beyond that, we're hugely limited by the lack of research. So we have individual centres with big cohorts that are providing a lot of the data on von Willebrand's disease. But there are a few collaborative international studies that are really tackling the key questions for people with VWD. And as part of this guideline, we provided key research areas of interest in order to drive forward these areas and provide further clarity for the next set of guidelines. Because of the research, the challenges in having a strong evidence base, there are no strong recommendations in this guidelines, but all the available data was reviewed carefully and considered prior to all the recommendations. What are the benefits? Well, as Nathan alluded to, that there's many people involved in this guideline coming from all different perspectives, not only people living with von Willebrand's disease, but also those involved in the basic science research, clinicians and research methodologists who provide a really stringent approach in order to have consistent outcomes for our recommendations. It's really been helpful to highlight the gaps in our research and understanding of von Willebrand disease. And we hope that this will help people with von Willebrand disease where access to care may be determined by payers and insurance. Importantly, it's been independent of any pharma involvement, and for each individual and the panel, the conflicts of interest were clearly stated, and they were excluded from voting on particular statements if there was any concern of a potential conflict. I think fundamental to this guideline is that it's taken multiple organisations, the ISTH, the World Fed of Hemophilia, the National Hemophilia Federation, the American Society of Hematology, all of whom have different interests and backgrounds, but have similar goals to try and improve care for people with von Willebrand's disease. And I think Nathan has pointed out a number of times how to find these guidelines, but if you have any interest in reading them, they're freely available to everybody, and they're available in different languages as well. And with that, I'd like to hand back to Dr. Cannell and thank you for your attention.
Thank you, Dr. Lavin. At this point, I believe we're going to turn it over to Nicolas Giraud, President of the French Hemophilia Society. Nicolas.
Yes, hello everyone. So as Nathan said, I was a participant, I was a patient in the diagnosis panel. So I was asked to present in this webinar, and there was a question that I was asked to me: where could things have been better, or what are the uncertainties as far as those VWD guidelines? So in order to answer that, there's 3 questions that I ask myself and that I'm sharing with you. Is this an innovative process to include the voice of patients in these guidelines? The way the process that was presented by you with the consortium or different entities like ASH, ISTH, WFH, and the National Hemophilia Foundation, just that consortium of 4 different entities is just first step of innovative process. But then also as well to have patients included both in both panels, diagnosis as well as management, and equally 4 patients on each side. That's also a very very innovative process. And I think we must underline that the effort to include the voice of patients in this process, that was a long process. It wasn't an easy process, I must say, though. To hear the voice of patients, we had different talks on different levels, different national levels. The French Hemophilia Society did a lot of work starting in 2007. Also, the National Hemophilia Foundation had a big reflection, a big event on von Willebrand disease in 2014. And that's where also in 2016 at the World Congress in Florida, also there was a big push toward the WFH to have to create a panel, a patient panel within the WFH. There were a panel, doctor panel for VWD, but there was no patient panel for VWD. And it wasn't that easy, but it was created. And I think also it was just a good alignment of different planets and good conjunction to create that work and to start. So it took a lot of effort, but it happened. And I think that the result is it's a great result. There's some step back though on that process, because when we asked, at least when I was asked, it was presented as a global guidelines for von Willebrand disease. And when I looked at all the people that were selected in the panel, as well management as well as diagnosis on both sides, health professionals and patients, most of them were from high-income countries, and that's, to me, it didn't really reflect a global guideline. And also, I must say that as far as patients, I was the only man, and we all know that von Willebrand disease affects equally men and women. So that's just a little drawback on that point. A second question that I asked myself is, are the von Willebrand disease guidelines long overdue? Well, to answer that question, I think we have to compare to others guidelines, and especially what matters to us, like hemophilia. If just on last year, end of 2020, WFH edited the third edition of the management hemophilia, third edition. So, and each country, I think a lot of countries have their own national guidelines for hemophilia, a lot of them. When you look at for von Willebrand disease guidelines, really you could count them on one hand and maybe on both hands by now, but that's it. It's very, very, very few. So yes, I think to that question, it's a long overdue. But that also means that it's not finished, because this has happened. I think there's other opportunities to continue and to adapt those guidelines to different profile. And then the third question is, can those guidelines be applicable everywhere in the world? Well, like Nathan said at the beginning, we try to create a perfect world, but we know that we don't live in a perfect world. And also the survey that was conducted, the response, over 80% of the response was from high-income countries, from patients and as well health professionals. So there's still a lot to do on those low-income countries. We still have to, I think, to try to adapt those guidelines to those profile low-income countries, because the means are different than the high-income. The diagnosis is very complicated. It's a long process, a different process. And that means that sometimes resources are not there. So how are you going to help? How are you going to manage people who are very, very difficult time to get diagnosed? So that's the thing, that's the limit that we have as of today. I don't want to be, I feel like I'm very uncomfortable position, because I feel like I'm very negative, which, I don't want to be negative on that part, because I think it's a great work has been done. And I really salute the work for everyone that has been involved in this process. But I think it's just a beginning. I think it's just a reality. I think there's still a lot of needs, and I think it needs to be adapted to those different countries, to different meanings, because von Willebrand disease, it's very complicated, but also we have to adapt to the reality of the field, and to be able to reach out to all those people in need. And I would say also that as far as the overdue for the guidelines, I think it was a long time awaited for patients, but also as well for health professionals. That's what we have to also to realize, that the health professionals, they need those tools to help them to manage and to diagnose on their daily practice. So that's what I think that we could retain as far as those guidelines. This is a great step. It has been a lot of work. It wasn't that easy, I assure you. Sometimes, you know, my mind was bubbling, but there's still a lot of work to do. And I think we really have to look at those guidelines and to try to apply them and to be able to fit them in every country, in every situation, which is not easy because that's a very tailored situation. But I think we have the willingness to spread those guidelines and to adapt them and to make sure that most people could use them, patients as well as health professionals. And that's it. Thank you very much.
Thank you, Nicholas. And now we're going to go over to Baiba for her presentation.
Hello, everyone. I am Baiba. I am probably the first person with von Willebrand disease on the board of World Federation of Hemophilia. And there are 4 points that I wanted to bring out today in this discussion. With the next slide. There are just like 4 small things that might change how you look at the von Willebrand disease in general. So first of all, it's the bleeding assessment tools in the next slide. These are very good solutions for us as patients and also for healthcare providers, how we can classify and understand if the bleeding that person is seeing is something really relevant. Because many of us patients with the von Willebrand disease over the life have had situations when our symptoms are being neglected, when somebody is saying that this is not a bleed, you are not bleeding as much as a person with the severe hemophilia, for example, and having highlight on bleeding assessment tools in the guidelines, I think that is like something that many of us have been praying for all of our lives, like to have a clear guidelines how to evaluate if the symptom is very severe or it's not just something that that is something that you can live with. And therefore, these symptoms would be the first thing that would guide if you need the treatment or don't need it on such level. For example, the same prophylaxis. Probably you as a person think you are bleeding too much, but maybe you are bleeding too much, but somebody who is providing your care doesn't believe and thinks that this is just a low von Willebrand disease, von Willebrand factor, which means that you can't be bleeding. But here you will have a tool how to evaluate this situation. In the next slide, I have highlighted the fact that, for example, many of us, I have been talking to people with von Willebrand disease around the world for many years, and many of us are being told that we are just low von Willebrand factor level and it doesn't count as a bleeding disorder, that it's not a rare disease. But here in these guidelines, we have clear distinction between levels of factor, in which cases we can or cannot be diagnosed with von Willebrand disease. And like today, the previous speakers were saying that somebody who has less than 50% of von Willebrand factor in their blood, the first thing how you evaluate is the bleeding assessment tool. You actually look at the symptoms. Probably this person doesn't have the lowest von Willebrand factor level in his blood, but he's bleeding. So definitely this person needs treatment. And also these guidelines speak very well about what kind of treatment in which situation you should use. And for us as national member organizations, in the next slide, we can we can use these evidence-based guidelines very clearly. I have sent them to my Ministry of Health already, and they are working on how to provide treatment. Because like Nicola said before, many countries have something on von Willebrand disease, but not all of us. And here we have something unique that is meant for all world and that we can adapt to our local situations. And for me, as a leader of a national member organization, it was always very difficult when I heard something in the international settings to bring it back and collect all evidence to support what I need and what I request from the ministry. And here, the wonderful team which has created these guidelines have already done the work. So we just have a guideline that we can easily ask our governments to try to establish in our national environments. And the last thing is something that was very interesting for me personally when I was reading these guidelines. Probably for many people, these are very easy to understand terms and conditions, but for me it was very interesting that here you specifically have told us what is a major surgery, what is a minor surgery, what is a frequent bleed. Because, for example, when we have something for the first time in our lives, we think that, oh well, it will go away and we don't need any treatment for that. But here in the guidelines we have very clear description of what is meant with a frequent bleed. So I think this will improve the situation of patients in the dialogues with their healthcare providers in terms that they don't have to argue, is this severe or it's not. So I'm very optimistic, and I really hope that the world will appreciate the work that the team has done, and we will have something common, and we will help these people who are suffering with von Willebrand disease all around the world. Thank you.
Thank you, Baiba. So I wanted to take a quick moment to point out that you can get a lot of information from the World Federation of Hemophilia website at www.wfh.org/VWD guidelines. From there, you can access the guidelines on the Blood Advances website. There's also quite a bit of information about different webinars and educational materials related to VWD, as well as these snapshots, which go through briefly what it is that the guidelines are accomplishing and what they've recommended, and there are translations into multiple languages. I also want to mention briefly the Global VWD Call to Action, which is an initiative to promote adequate care and treatment for people living with VWD around the globe. 48 national member organizations have already signed on to integrate VWD into their advocacy and outreach work. And if you'd like more information on the WFH's VWD Initiative program or the Global VWD Call to Action, visit wfh.org/VWD. So at this point, we're going to move into questions and answers, and we have quite a bit of time to go through them. What I suggest is that you please submit your questions in the Q&A box, which you'll see at the bottom of your screen. We also have some questions that were submitted along with registration that we're going to go through, as well as some questions that have already been submitted. So at this time, I'm going to ask the panelists to turn their video on. Okay. And I think we're just going to jump right into the questions. The first one, I'm going to pose to Dr. Lavin because of her presentation. And one of the questions that we got was, how long should tranexamic acid be used in the postpartum period?
Thank you, Dr. Cannell. So in the guideline, we address this and suggest the use for 10 to 14 days postpartum, so 10 to 14 days after delivery. And that will be at a dose, if you're in Europe and you use the 500 milligram tablets, it'd be 1 gram 3 times a day. If you're in America, there's slightly different formulations. So it's, I think, 1.3 grams 3 times a day. And that would be for 10 to 14 days after delivery, or longer if the bleeding is still quite significant or if it worsens. I think practically it's useful for women to get that initial prescription advice for 2 weeks, but to also have on the prescription maybe an additional week, so that if they do notice that their bleeding starts to worsen when they come off the tranexamic acid, that they can go back on and contact the centre, so that they're not left, say, over a weekend with a very heavy lochia.
Great, thank you. This is a question for all of the panelists, and I'm actually going to start with Baiba and Nicola, because I would love to hear their responses to this compared to what Dr. Lavin and I might say. And so the question was, what are the panelists' top 1 to 2 guideline recommendations that they believe will improve the lives of those living with VWD, and why? So essentially, what were the recommendations that you were most excited to see get published and answered in this guideline? Baiba or Nicholas?
Okay, I will start. I was like extremely happy when I was reading through both papers, and I really want to duplicate myself, so I had more time to translate everything and bring it to my people in the local language. But I really love the tables in the guidelines. I think the one which shows how to diagnose is one of the most important, maybe for me, because for all my life I still haven't had the answer of which type of von Willebrand disease I have, so I don't have the treatment. And also because it was personally related situation about postpartum bleeding, that tranexamic acid is pretty cheap medicine that anyone can buy, and I will try to do my best to include it in reimbursement list in my country, and I will try to get it there for women that need it. So I think these are 2 most, like, personally most important points for me. Thank you.
Thank you. Nicola?
Yeah, well, being inside is not maybe so easy, but yes, what I would like to say, what I'm very excited about it's that, especially on the diagnosis, is, well, even though on management, the introduction of the notion of shared decision making, and because, you know, health professionals, they like to put you in boxes. They like check marks, but von Willebrand disease is not a check mark, and so there's a lot of in-betweens, and that's what I think it's a great message for patients. It's a great empowerment for patients to have that opportunity, that shared decision makings, and to have those gray areas, because it's not one fits all, and that's, I think that's, you know, it's one thing that I already pushed for it. And that's what I'm very excited to have that. And the management panel is the more frame notion of prophylaxis. When do you introduce prophylaxis and how and so forth? Because it's also a big gray area. It was a big gray area before for a lot of health professionals, for patients as well. And I think that's also that frame, it helps it to be, so that I'm very excited about.
Great, thank you. Michelle, how about you? What were you very excited to see in these guidelines?
I think you can predict it, that definitely the postpartum tranexamic acid gets a look in. I think in terms of what I really enjoyed about the guidelines, just to kind of echo, I think what Nicola is saying, is that at every question, you know, we did the standard approach that every physician takes, look at the evidence, you know, see about the risks and benefits. But then there was a really important part in every question where you had to look at equity and access. And I think that's just fantastic. Like, how was our recommendations going to impact on an individual patient who's trying to access care? Or is it going to make it more equitable for patients to access care? So if we recommend a really expensive treatment that no one can access, well, then that's not equitable. But if you can actually improve care by, you know, simple changes, inexpensive medications, that has a huge impact on equity. So I think that was really important for me, that was such a strong consideration in all our questions, and I was really, I hope that that does really reflect in the real world when these guidelines are implemented. In terms of the two recommendations that I found most exciting, it was prophylaxis and tranexamic acid, because I think there's so much uncertainty for physicians and even for patients. Should they ask for prophylaxis? Is this a thing in von Willebrand's disease? Should we be using it? When should we use it? And people being told that maybe they don't need prophylaxis when they do. So I hope that that provides some clarity and helps people to access prophylaxis easier and encourages the use of prophylaxis. So maybe we might catch up with hemophilia sooner rather than later. And for tranexamic acid in the postpartum period, I think that's so important because it's something that's been kind of hovering around the edges of all our conferences all the time. Should we be using it? Is this something that we should do? And you know, when we reviewed the data, the perception of that the risk is low. The perceived benefit is high. We don't have a lot of robust evidence specifically in von Willebrand's disease, but when you look at tranexamic acid in prevention of primary postpartum hemorrhage, this has a clear role in all women giving birth. So we know that women with von Willebrand's disease are particularly at risk of bleeding immediately after delivery and when they go home as well. So I'm really hoping this is going to change that and actually bring attention to the area that we need to focus on. We can't just be happy and satisfied that we have a safe delivery for the mum and the child. We actually need to reduce bleeding when people go home as well, so they can have a much healthier postpartum period and enjoy that with their babies.
Thank you. I will say that I technically have 3 favorites in this guideline. 2 are in diagnosis, and one I've already spoken about. The 30 versus 50 cutoff, I think, was one of the most important to be able to come out and make a strong statement about cutoffs, because we wanted to make sure there was access for all. The other one that I was very excited to see was a recommendation around the use of the newer assays, particularly GP1BM. All of us that have used ristocetin cofactor-based assays really struggle with them. It's how is it shipped? How is it run? What's the accuracy? We found out that there are genetic polymorphisms that make people less responsive to it, to the ristocetin. So, you know, in medical decision making, one of the most important things is knowing that you're going to be able to send a test that is reliable and accurate. And so having that out there, I think, is important, especially here for me in the United States, where access is fairly limited. So we're hoping to use this as an advocacy piece for greater access to these newer assays. And then in terms of management, I was so excited to see something on prophylaxis. You know, it affects a small subset of patients, but for those in whom prophylaxis is needed, it seems to have a huge impact on quality of life and outcomes. And so I was very excited to see prophylaxis. And what we've also heard is that even patients who don't need prophylaxis know someone who has severe bleeding and would benefit. And so it is affecting the community in a different way than many of our other recommendations. So moving on to the next sort of questions that came in, I want to make sure we get some of these covered. This one is I'm going to ask for Dr. Lavin as well, and it's about the use of subdermal implants. Is the use of subdermal implants recommended for contraception in young women and to help avoid pregnancy and the possibility and menstruation? And what's your take on subdermal implants versus other methods?
I'm sorry, I had a little lost internet. I presume this question is coming to me, Nathan, is it?
Yes, yes.
Great. I was going to hop in anyway. So in terms of the implant, there's kind of 2 separate questions there. One is about efficacy for contraception, so if you don't want to get pregnant, and the other one is how it affects your heavy menstrual bleeding. So if there's physicians or interested patients, there's really, really excellent guidelines from the UK. It's part of the Royal College of Obstetrics and Gynecology. So they have a faculty of sexual and reproductive health, and they regularly review and update guidance about all different types of contraception. So that's a really good resource, not just for people with bleeding disorders, for everybody. And in terms of the implant for heavy menstrual bleeding, there isn't enough evidence to know if it impacts on heavy menstrual bleeding. So it's not currently licensed or recommended, at least in Europe, as a management for heavy menstrual bleeding. It does help with pain, and it obviously is an effective contraception. So it's very effective at not getting pregnant, but it wouldn't be my first choice in terms of heavy menstrual bleeding management, because we don't have that robust database behind it. If a woman with von Willebrand disease is looking at options, you can use combined oral contraceptive pills, so hormonal therapies, if you don't want to get pregnant. But if you're not thinking about getting pregnant in the next 3 to 4 years, a really excellent option is to look at the intrauterine devices, so the coils, and they can be left they could be, inserted for 5 years, and they provide effective contraception, but they've also proven to reduce heavy menstrual bleeding. You mightn't see a benefit for the first 6 months because your periods can become slightly more irregular, and it may not be the practice in other parts of the world, but certainly here we would use tranexamic acid cover for the first cycle or two to reduce the rates of expulsion, because they can be, if you have a very heavy period and you just place the coil, it can be passed out. That's kind of a downside if it tends to happen earlier rather than late. So for the implant, good for contraception, not my first choice for heavy menstrual bleeding. And also they can be left in place for 3 to 5 years. Then you have to, there's often a lot of scar tissue around them. So I don't really like an invasive, or something going in under somebody's skin that may need a lot of surgery to get that taken out if you have a bleeding disorder. So that's another reason that I don't tend to recommend them as much. It's a very individual choice.
Thank you. We have a question about long-term side effects of using tranexamic acid. I'll just say what I do, because I actually saw a young woman yesterday and had to provide some counseling about tranexamic acid, is that in general, we find that it's very safe. I find that with any medication, especially a 3 times a day medication as TXA is that you can have some nausea, upset stomach with it. I find that most patients tolerate it without any side effects. I think what's also important when talking about side effects of tranexamic acid is what are not side effects of TXA. And so there's a common misconception out there that it is not safe in conjunction with combined hormonal contraceptives. In the United States, there is an FDA black box warning on the combination, but we do feel that it is a safe option for women who have bleeding in spite of combined hormonal contraception. And so I will frequently combine it with hormonal therapy in women who are not optimally controlled. I think it's also important to recognize that TXA is safe during breastfeeding. That was a very specific call out by the panel during our discussions, and we would love to have more information out there to share that, and that we do use it in women who are breastfeeding postpartum. Dr. Lava, anything else that you would say about tranexamic acid?
Yeah, so I think it's when we're talking about long-term use of tranexamic acid, this isn't a medication that you're using every day. It's a medication that's used for treatment of bleeding. So if you have nosebleeds, if you have heavy periods, so it's used, or for surgery prophylaxis, so it's used intermittently. So it is a kind of prophylaxis as well in itself. And certainly, just as Nathan mentioned, there's been a lot of publications in the literature in the past about thrombosis risk. A lot of these originate from the 70s and 80s, where there was high dose contraceptions being used with 50 micrograms of estrogen as opposed to the 20 and 30 that are more standard now, in patients who had multiple other risks who probably wouldn't have been prescribed the pill in the current climate or nowadays. So and when you look at the actual clinical trial data where tranexamic acid has been used in a variety of clinical settings in very sick hospitalized patients, some with cardiovascular disease or some with even acute leukemia, it's been tried, there hasn't been an increased risk of thrombosis coming through in those studies. So there's randomized controlled trials involving more than 50,000 people, and thrombosis again and again, it does not come through as a signal. So I think it's more of a perhaps physician perceived risk rather than an actual evidence-based risk. For the I counsel patients in the same way that Nathan does, that I will use it with combined oral contraceptive pills if there's people who are still having difficulty controlling their bleeding. And it's a different group of patients that you're talking about, because the people who have bleeding disorders, their main problem is bleeding. So again, you're using it to try and help that, and it certainly has an improvement in terms of quality of life.
Thank you. This is a question I'm going to pose to Nicola and Baiba, and it's about how to contribute to having a strong local association with a focus on VWD programming, especially in the context of existing bleeding disorders programs. So how do you work with your organizations, and what have you find as successful strategies?
Well, I'll start this time, Baiba, if it's okay with you. It's a great question. It's not always easy. It's a great debate within our community that we try to address. But I think that the basic thing is reach out to those people who are concerned with VWD. Offer them a platform, offer them a space for them to gather, to speak, to exchange, to share the experience, and provide support to build advocacy, to create actions, to hold events, give support. I mean, as far as already existing entities or association or foundation, I think you have to welcome them, because what's going to bring to the society, to the community, it will bring for everyone. I mean, if I start with the example from the French Association, the Von Willebrand peer group started to try to address the issue with gynecologists, which is a big issue. But it's not only the issue for Von Willebrand patients or women. It's also an issue for women who are concerned with hemophilia, with low level of hemophilia, or platelets, or others, or the other rare bleeding disorders. And so it's very transversal. So I think you have to give the space, provide, you have to help to try them to have that group to keep it motivated, but to show them that they're welcome. We are one family, and so I think that's how you could start.
I can say that I am still learning how to do it properly. My country is very small. We are just 2 million people, and something around 300 should be with von Willebrand disease. And I have only 70 people officially registered in the rare disease registry at the moment. And because it's so small, I am trying to help each of these patients. When they turn to society individually, I have been trying to convince them to make a working group for many years now, but it's nearly impossible, because like everyone thinks that I can do everything for them. And for me personally, it was very difficult to start as well, because when I was elected as the president of Latvia Hemophilia Society, I had to deal with hemophilia. We had no treatment at that moment. It was like very bad situation. So more than 7, I think, years I was dealing only with that one. And now when I'm brave enough to start doing something about von Willebrand, now I have the new guidelines. And I'm very happy that the World Federation of Hemophilia has prioritized this disease as well, because many years we've been asking for solutions and help and raising awareness. And look where we are now. We have more than 100 people listening to this webinar, and I think it will really impact and make the change in the future.
Thank you both. So going through a couple of other questions that we've received. One is about recombinant von Willebrand factor, co-administered with recombinant factor 8, that once it's licensed, will there be any circumstances other than availability and cost where plasma-derived VWF is preferred? I'll maybe start off with this, and then Dr. Lavin, I don't know if recombinant VWF is available in Ireland at the moment. You know, I think this is a very large discussion about what is the efficacy and safety of recombinant versus plasma-derived. You know, there hasn't been the same level of concern, I think, for plasma-derived products in the VWD community that many of our patients with hemophilia experienced with plasma-derived products. The available options have been very safe for many years. And so many patients, in my experience, feel comfortable with their plasma-derived products and haven't felt a strong desire that going to recombinant would be something that they really push for. I do know that there are some data suggesting that fewer doses may be necessary, or lower doses of recombinant may be necessary in order to achieve hemostasis. And I think that, you know, understanding these options of when it's going to be best available is going to be important. And so looking at comparisons to be able to consider it. The guidelines did specifically make a call out of a future research priority of comparison of plasma-derived versus recombinant therapies for different indications. And we also talked about the addition of, for instance, anti-angiogenic therapy, something like bevacizumab, to treat GI bleeding, AVMs, in patients who have it, and whether or not that would be important to combine, or combining tranexamic acid with these different therapies, how does it look? So we have many, many questions that we want to answer. One of the things that I would say is that in developing the guidelines, the chairs came up with over 100 questions that we would want to answer, and then we had many more added to and edits from the panelists, and then we had to prioritize essentially 20 questions total between the two groups. So we left most of the questions in draft form with the hopes that with future iterations or availability of data that we'll be able to go answer other questions such as this one. That kind of segues into this next question about that the guidelines seem to be quiet about the management of pregnancy and delivery itself. And Dr. Lavin, what would you say? What aspects do you pull in from the guidelines into your practice, and what's your general approach to management in the peripartum setting?
Yeah, so I think it's a fair point. I suppose we were restricted in terms of having, you know, we weren't able to pose questions and answer questions on everything for von Willebrand disease extensively. So we were guided by the Scopian survey as to where people felt the current knowledge gaps were when we looked at, you know, which questions had to be prioritized to answer. And that's why there was the focus on spinal anesthesia and postpartum hemorrhage, because they were the areas that felt to be kind of controversial at the moment, or areas of uncertainty. In terms of management of von Willebrand's disease in pregnancy, it will largely depend on your subtype, so that we know that for some people, if you have levels in the 30 to 50 IU per deciliter range, or if you're type 1, some patients with type 1 will also increase their levels in pregnancy. So you can see that the levels will increase. But I suppose what's unclear is what threshold is required to prevent bleeding at delivery completely. And that's the subject of a lot of clinical trials at the moment. If you have type 2 or type 3 von Willebrand's disease, you're unlikely that your levels will increase significantly at all. And you still will need cover for delivery in general. If you have type 2b, you may also need platelets. It just depends on what your platelet count is at the time of delivery. So I think what it really comes down to is when we see somebody who is pregnant, that we ask people to contact us if they become pregnant before their next annual review. If you're pregnant, then we follow your levels. Usually we do a level in the first trimester, and usually around 28 weeks, and we may need to do one further on if the levels are coming up but maybe aren't quite at the level that we want them to be yet. But it's about developing an individualized pregnancy plan, so that every patient who's pregnant with von Willebrand's, this may not happen in every setting in every country, but it's our current practice that we would provide not only the obstetricians, the pediatricians, the hospital, the doctors with the the plan for delivery, but the patient. And that's developed with the patient and with their obstetric team. And we advise whether somebody needs treatment before delivery. If they need treatment, do they need their levels monitored? If they need their levels monitored, how long for? How many days of treatment they require? Is there any precautions for the baby? If the inheritance is known, what the risk to the baby will be at the time of delivery, and whether they're suitable for spinal anesthesia or not, or how that should be administered if there's any particular precautions. So that's all very clear, and we aim to provide that by about 28 to 30 weeks. Because babies don't always come at 40 weeks, they can come whenever they like. So we make sure that gets emailed out. It doesn't get sent in the regular post, just in case. And back in the days when people used to be able to travel, we'd advise women to carry it with them in case they were in a different part of the country or world and the baby decided to make a sudden appearance, so they would have a letter of introduction to any obstetric facility they were going to with their pregnancy plan available to them. So that's how we manage pregnancy. But I think, we often forget, as I said before, there's a tendency that once the baby's delivered, we forget about the postpartum period. And I think women need a little bit more intensive support and monitoring during that period of time, because it isn't often explained that you even get bleeding after you have a baby. I don't think, sometimes the obstetricians forget to mention that vaginal bleeding is normal after a baby and that you can have a heavy period. And you're dealing with a group of women who already have heavy periods to start with and who may normalize heavy vaginal bleeding. So they need to have clear indicators as to when they need to contact somebody, when the bleeding might be too much, because it's not uncommon, unfortunately, to see women iron deficient when they come back for the review, maybe 3 or 6 months after having the baby.
Thank you. This question for Baiba and Nicholas. There were some questions submitted beforehand and questions in the chat about connecting with other patients. And can you talk about what you do at your local level, or even what resources you've seen through the WFH for patients with VWD to connect with each other for support?
Okay. What do you do to connect? I'm afraid I'm going to repeat myself, but I think, first of all, to connect as far as all what's available, the tools or the publication, I think you have to try to pass on those information, try to have connection and information to those patients and to those people. And I think you try to have a space for them to be able to express, to address their concern, their questions, to talk about their situation. Also, I think that's also the other thing. You have to try to address their situation. You have to talk to them personally before then after, maybe you could hope that they will get involved and, they could start to carry out the voice or to start to, do project with you. But I think you have to talk to them and to address their issue, their personal issues, because that's how it starts. That's how the involvement, that's how, the conversation starts with their own personal stories and all. So you have to be able to relate and understand that also that, if the community is full of people concerned with only hemophilia or others, and somehow it's a bit related. It's hard to relate. That's what I heard also a lot from and the French Hemophilia Society throughout our networks, our chapters. A lot of head of chapters say, it's hard for me to reach out, to connect, to understand, because I'm not concerned with this. I don't. But actually, it's like, the living with is kind of similar. So, that's how you have to start, but you have to relate at one point and to start to address their concern.
I would encourage all patients to be more brave and approach their NMOs themselves, because that is the place where you can find somebody who can take care of you and help you connect with other patients. We have, for example, because we are so small, then we can't have chapter meetings on von Willebrands, and we actually have very few doctors who are able to speak about it. and therefore we can't make conferences and events for people with von Willebrand's in Latvia like in other countries like Ireland. I'm so jealous. I was in some of these online meetings in other countries, and I'm really surprised and happy how patients talk to doctors and how doctors are welcoming patients and helping each other to know more and better. I can't do that in my country, but because of this crisis and doing and having everything online, we are always approachable, and we have Facebook groups and things like that. And I also encourage my patients to search for information in other societies as well, because many of our patients live in other European countries. So for them, it's also better to go directly to communities that are located in those countries where they live. But of course, we are always here and always helping people. And we always need volunteers for our programs and events.
Dr. Lavin, I think you also wanted to comment.
Doctora Lavin, creo que usted también quería tomar la palabra.
Just one thing to just for following on from Baiba is that even if you're even if you don't have,
si no tienen,
sorry, I'm not sure there's somebody speaking there as well.
No estoy.
Excuse me. So if you have very limited resources in your country and you're hoping to like you want to get more information, there are other countries that will be happy to have you involved in their webinars, and that's the one advantage, the only advantage of COVID, is that we can connect so much easier with each other internationally. So I know the Irish Hemophilia Society run both hemophilia and von Willebrand disease webinars 3 to 4 times a year, and would be delighted to have anybody who wants to join in. So I think if you emailed them and asked to be added to a mailing list, they'd be more than happy to send you information about any upcoming webinars. And I'm sure there's other organizations in countries with larger representation that would be happy to do the same and in different languages. So, you know, reach out to each other. This is a great international network we have, and we should be supporting each other throughout this, because that's how we move the entire field forward.
Thank you. I think we've got time for one more question, and then we'll be at the end of our session. This question, I think, is timely and important and globally important. Is the coronavirus vaccination safe and recommended for people with VWD? And I would first say absolutely. I think that the global effects of coronavirus have been very apparent about the morbidity and the mortality that we have witnessed in just the last year and a half. And we know that vaccines are very safe. We also know that a number of patients with bleeding disorders have safely received their vaccines in the last several months as it's been available globally. The WFH does have some information. I'm going to copy a link into the chat to a news release from the WFH in December about vaccination, but you can find more information on the website. And it's important to speak with your physicians directly. Because this is an intramuscular vaccine, and we generally avoid those in patients with bleeding disorders, some patients with severe bleeding phenotypes may need to have factor administered prior to the vaccination. It's important to hold pressure over the site afterwards, but most patients, even those with severe bleeding disorders, have received this very safely, and so we do recommend it. We are at the end of our session. I want to thank our panelists, Dr. Michelle Lavin, Baiba Zimala, and Nicola Giraud, for participating today, and encourage all of you to go online to the WFH website to learn more about the guidelines and to get access to our educational resources. And thank you very much.